So I start with a handicap, in fact, 2 or 3 handicaps. I'm following Dr. Peisman, a real master of surgeon. And I'm substituting for Dr. Feliciano, another master surgeon. So there is no way that I can do any justice for either of them giving this talk. Just as an excuse, not an excuse, but just to give you the facts. I was told about this last night at 7 o'clock. So please take that into consideration. So it's a great privilege to talk to you about some of my experiences with trauma as a career. So my initiation, if you will, or I was born in trauma surgery in the South Bronx, 1975. When I went to the Lincoln Hospital, sometimes called the Fort Apache of the Bronx. And that was the time of crack cocaine. People were just going crazy, killing each other. And violence was worse than wars. But that was great for us in surgery because we were up all night operating on stab wounds and gunshot wounds with these long lines waiting for the operating room. And then 2 years down my career, I don't know if any of you remember the blackout of New York City, 1977. The whole city went dark, and everything went haywire. So we had, in a spate of about 30 minutes, about 55 admissions from the emergency department, and they kept coming. So they had to actually open up 2 floors of patients' care to accommodate all these patients. So that was my initiation into trauma, and fortunately, it was all penetrating, and I just gave you some examples of all the various stabs and gunshot wounds we saw. I gave you only the more acceptable ones. There are all kinds of penetrating wounds to different areas of the body in both sexes. And very interesting tattoos. My only regret is that I didn't give a colostomy to this patient right there. But I soon realized that trauma as a career is great because it's a science of true generalism. It's a science of ownership where you really own your patients, take care of them. You develop lots of relationships with various groups, not only patients, but drug dealers, drug addicts, all kinds of patients. And then you're operating on the best machine, which is very young. All these patients with penetrating trauma are only in their decades, second, third decades, very healthy. So no matter what you do, they eventually get better. So you can claim all the credit. And then it's great for teamwork. It gives you a little perspective about life, and also it's great for teaching young students about anatomy, physiology, and that's where we picked up all the physiological principles of resuscitation. And it is really fascinating to see if you do all the correct things in the sequence that should be done, they rapidly respond to you. All these abnormalities of physiology come back to normal. So it's a great lesson in anatomy and physiology. And trauma care, gradually we began to realize, is what is all about doing the right thing. And I have never found any other specialty that does the right thing all the time, or most of the time. We have a lot of integrity. We take a lot of risks. We are very creative in finding our own solutions. And if you look around this hall, this is replete with examples of initiations of enthusiasm, of initiatives, homegrown lessons and homegrown tools to take care of patients. Dr. Boreas is sitting here in the front row. He has introduced the Bogota bag, which has revolutionized the treatment of trauma care. And he actually showed me some of his homegrown methods of treating small intestinal fistulas with suction machines and suction apparatus long before we heard about negative pressure therapy. So it has a lot of opportunities for vision and for courage. If you believe in yourself, if you do the right things, the patient will respond to you. We are always doing the right thing because we are the servants of this great specialty called trauma surgery, but we also are the leaders in that specialty. And we communicate. We are not afraid to talk to people. We are not afraid to call in specialists when we are not completely confident in what we are doing. We have great skills in listening. We listen to people. We create partnerships. And it is all about collaboration. I think as Dr. Ivatury very nicely expounded a little while ago. And this is sometimes called a purposeful paranoia. We are continuously questioning everything we see. We are not accepting a status quo. We are saying, can we do something better at this point to this patient? And we always fear the worst and prepare for it because we understand that if anything can go wrong, it will go wrong. And then the ultimate lesson of all, if everything is going well, you probably overlooked something. And this is Dr. Harkin, who is talking about surgeons versus internists, and I found it absolutely fascinating. So he compared surgeons with internists, and he says that surgeons, we must do something before we know what is going on because of the very nature of the urgency of the situation. So we have to tolerate some amount of error. So in tolerating error, we have the right to be wrong because we don't have all the information that forces us to work and decide in urgency. And when we are wrong, we must and we always do acknowledge our errors and try to minimize the consequences. So that is all about surgery if you think about it. Now we tend, as we have to, dive into the swamp and look around for the alligators. We have no right or we have no time to stand around and think about a problem. Now compare that with your internist colleagues. They analyze the swamp waters for the osmolality, acidity, chemical structure, nutrient content, to see if that water will support alligator life. So that's the basic difference, ladies and gentlemen. I'm sorry for any internists in the audience. I hope there aren't any. So we surgeons are the plungers, they are the planners. We are uncertain, they are absolutely certain. We require a deadline, and they prefer to wait around. So we require the right to be wrong. While they can sit around, they can aspire for perfection, they'll probably never get it anyway. And then, in my fortunate career, I had some great lessons of inspiration. Dr. Francisco Holguin took me to my first international conference in Bogota, and I had the great opportunity to watch some great people dance around here. Dr. Birolini and Dr. Ruslan. I don't know if they do this all the time, but a very young-looking Dr. Maddox, he doesn't look much different. I don't know what he does to himself, but. And then a very young-looking Aurelio here. I think he's still looking the same. I think he does, again, some facial surgery maybe. And Dr. Moore here. So these are some of the people that inspired me to stay on. And my good friend, Dr. Ricardo Ferrada, and Dr. David Feliciano. So when I first went to the South American conference, I presented my SEEs and cardiac injuries of about 200 patients collected over 20 years. What happens next? Dr. Ferrara gets up and says, this is my experience in the last 1 year with 250 cardiac wounds. So that, ladies and gentlemen, describes the Pan American Trauma Society for you. And Dr. Feliciano has always been a great inspiration, leader, advisor. I still call him up in the middle of the night asking how to take care of patients. And Dr. Rodriguez here, who is actually the godfather of this society, I don't know if he's still singing, we'll find out tomorrow night. I guess he is. And even when he's not singing, he's always talking, so it's the same thing. And this is my group of esteemed colleagues. You can see Dr. Raslan, Dr. Kimmer Mall, who was a former president and former executive director, who carried this society for a long time. Dr. Carlos Barba, Dr. Gomez, and here is our president, Dr. Puyana. Unfortunately, Dr. Ortega could not be here. And he's, of course, Dr. Peitzman and Dr. Puyana. The combination has actually set us forward in this decade in our path for where we are now and what we aspire. So Andy and Juan Carlos, greatly indebted to you. And then I don't know if you ever wondered why birds always fly like this in a formation. And I found out that actually this is because it's very helpful and it is a real team effort, just like trauma has to be and is. So each bird flaps its wings. It creates an uplift for the bird immediately behind. So this V formation increases about 70% of their flying range because it reduces the friction that air has on this formation. And if a bird falls out of the formation, it feels the drag and resistance, and immediately it gets back into the formation so that this is maintained. And the geese or the guys behind, just like our trauma surgeons, who are always supporting you from behind, honking encouragement to those in front to keep up the speed. And when the leader gets tired, it is time to give its place to another one and go to the back. And these are actually called the penguins in Australia. If you go at dusk to this particular island, it's fascinating to see all the penguins come out of the water. They always group on the shore first because they have to cross the road to go to all their homes. So they all get together. So the leader looks to the left, looks to the right, makes sure everything is safe, gives the signal, and they all, as a group, go cross the road. And once they cross the road, they don't go immediately to their homes. You see that these groups around, standing, socializing for a few minutes, I guess saying goodnight to each other, and then going back to their homes. This is absolutely fascinating. But our specialty is changing. We are having this increasing workload. We are having this increasing complexity, more severe injuries, more comorbidities, more older people, more severe crashes, to the extent that our patients can't be taken to the operating room. We have to do majority of the procedures by the bedside. More and more complex care, advancing age, which makes it very difficult. Unfortunately, they are not all young stab gunshot victims anymore. And 20% are increased over the age of 65. They have prolonged ICU stays, multiple infections, increased length of stay. And then we get into all the difficult areas of end-of-life discussions, which are not always very pleasant. And the trauma surgeon is having a burnout, quite expectedly. And you can see that this is a survey done by East a few years ago, and they showed that 42% are chronically overloaded at work, and 45% actually have to choose between a family and work. 60% actually considered quitting trauma, quitting medicine, and so on and so forth. Not a very attractive picture. And then Dr. Jane Moore gave this wonderful presidential address in 1990s where they actually looked at a surgeon's life and came up with some astute observations, which I thought you might find interesting. He called this title of the talk, Swimming with the Sharks Without the Family Being Eaten Alive. And he showed that there is a widened emotional distance within the family, loss of intimacy, and the gradual separation of interests and separation of people. And he showed that the balancing time at work versus family is the most important stress. And this is what the academic surgeon said in his survey. And what did the academic surgeon's wives said? Feeling of insignificance, lack of commitment, a delayed gratification, lack of intimacy. And this last comment I found was absolutely shocking. Being married to an academic surgeon is like living with an alcoholic, except he won't beat you or take the grocery money away. Wow. Another survey in 2006, which looked at work-life balance, a myth or reality, and they again showed the increased challenges in the business of trauma. Again, trauma surgeons get addicted to work, spend a lot of time within the hospital and their patients, probably not as much time to their families. And it is really, we are the problem. And the work of the nurses is not that much better either. The average age of the RN is climbing, at least in the United States, that's true. Current ratio of RNs in their 40s to 20s is about 4:1. So the whole group is getting older. And 40% of the hospitals in the hospital setting report burnout. Job dissatisfaction is 4 times higher. Burnout was a major component why nurses leave their current job. Lack of feedback from supervisors. And then there is a declining supply side contributing factors. There is a declining nursing school enrollment, shortage of nursing school faculty, a decline in the RN earnings, increasing numbers of RNs leaving the profession. So you can see that by 2020, the average RN vacancy rate will increase by about 20%. So can you imagine the great problem we're going to have? So we have to acknowledge that the face of trauma and the face of trauma care is changing all around us. It's getting more and more complicated, and our facilities and our equipment, our advantages seem to be dwindling. But just consider all the accomplishments that we have. So just to look at the entire spectrum of the rainbow, we did accomplish quite a bit in the stable patients. We are beginning to apply the minimally invasive surgery. This is spearheaded by Latin American countries like Colombia, Brazil. They really showed us how to use these minimally invasive techniques in the care of the trauma patient for the betterment and benefit of our patients. We define non-surgical treatment. Granted, as we heard from Dr. Peisman, we are tending to push that pendulum too far, but if we are careful, that is a real advantage for our patients, that we can actually treat them successfully without complications, without operating on them. And we have become non-surgical surgeons, which is really remarkable because considering that we like to operate, we have begun to define the craft and art of when to operate and when not to operate. And look at the accomplishments we made in the face of these humongous hurricanes that we face professionally. We improved our resuscitation parameters. We have introduced the concepts of damage control surgery. We have begun to define the problems of the open abdomen and actually begun to use that very effectively and with much less morbidity. And we actually have shown data to show that the last decade has seen a remarkable decrease in the incidence of multi-organ failure in the most severely injured patients, probably based on a number of factors, starting with pre-hospital care all the way to the intensive care, resuscitation, etc. And look what we have done. We are the first specialty to look at what we're doing, to really criticize ourselves, to self-assess. We have a self-imposed triage systems. We have regionalized care so that the patient, at least most of the time, gets to the best place at the best time. And we have become truly multidisciplinary. Can you ever think of any other specialty that employs as many disciplines as trauma surgery or acute care surgery does? And we have improved our surgical societies. We have accepted national standards of trauma care that are becoming more and more frequent in the entire world. We have defined the optimal resources document that really needs for a very efficient care of the injured patient. We have matured our centers. We're trying to mature our systems. We have improved our outcomes. We also have begun to improve our research so that it is not entirely non-applied basic sciences, but that is truly translational, so you can get the maximum benefit for the money you spend in basic research. And because of this, look at the remarkable accomplishment we accomplished in the last decade or so. We take these complex patients in extremis, use all these techniques and all these methods and all these concepts, and we reduce the mortality to about 50%. At one point, this used to be about 75 to 90% in these patients. So damage control surgery and all the accomplishments that we have made are something we should be proud of. And then we globalized our trauma care, so we are beginning to talk internationally so that we can learn from each other and apply those principles for the benefit of our patients. Our societies have become multinational. We have begun to partner with organizations like the WHO, which now has trauma as the leading initiative that it looks at. And you heard about the World Trauma Congress we had in Brazil, which brought together the entire world talking about initiatives in preventing and treating injuries effectively. We are actually trying to prevent trauma patients coming to our hospitals because we are trying to prevent injury and we are trying to prevent violence. We got so many initiatives in this area that is actually becoming a very advanced science in itself. And then we have expanded our area of clinical practice, not only to involve trauma, but also to involve critical care and all those acute general surgery patients who really never had a safety net for them. Many emergency departments did not have a surgeon looking at these patients promptly, so that the patients will get looked at the next day, perhaps 24 hours later, with increased morbidity and mortality. And now, in the United States, as well as in South America, at least it's beginning to happen that we are there in the hospital as a safety net for the patient who comes to the emergency department, not with trauma, but with an acute general surgical condition that requires immediate attention. So this is something that will hopefully, with Dr. Peitzman's leadership and the WAST and the SPT and all the other organizations that are here from different countries, will really evolve into a specialty that the patients can benefit from. So we do have to find some solutions for some of the problems we talked about, especially in regards to personnel. And I think that is where that we all should look at ourselves, perhaps change ourselves a little bit. We have to maintain quality family time. We have to appreciate what we have as a family, and we have to try and accommodate to preserve that family. And these are the recommendations that came from Dr. Jane Moore's survey. and which has been borne out by every survey since then. Now we talk about Generation X and Generation Y and how much they are different than the generation of the baby boomers. We have to accept that. We have to understand how they think. We have to accommodate them. And they desire personal time. They want a balance. They don't want only professionalism like we used to have. They want beyond a profession. They want a family life. They want to enjoy their life to the maximum. And we have to accommodate to that, and we have to make sure that they get what they need. So we have to shorten the training period if we can. We have to shorten our work hours, which, as you know, in the United States is happening, which is sometimes we complain about, especially in surgery, but I think it's a good thing that the younger people have more time for do other things so that they can become a better person and then appreciate their profession better. They should improve the quality of work, and most importantly, they should have quality time off. So when they are off, they can really have time off, not like what we used to do. We are always on call for our patients. It's interesting that when you look at this survey of surgical training and what it should be like and what should be the aims, these are the various things that different groups came up with. The resident surgeons wanted technical skills. The attending surgeons wanted mostly judgment. And the surgical nurses said, why don't you doctors speak to us? We want better communication. And this is a very interesting thing. How many, can I have a show of hands of students and residents in the audience? Thank you. Can I have a show of surgeons with more than 10, 15 years of experience? Okay, so this survey is very relevant to what I just asked. There was a very interesting study which looked at why medical students say they don't want to go into surgery. And then what they did is they had an intervention whereby every student was put in contact with a senior surgeon. Just talk whatever you want, just have a communication. And look what happened. After the post-intervention, it's just a brief 1-hour encounter. After the post-intervention, the concerns about debt and length of training became less important. And they said, boy, you have a fantastic career. I would love to be in your shoes. So ladies and gentlemen, if you're a senior surgeon, find a student or resident that you just want to talk to. Just talk to him. As I did, and Dr. Lucas, I see here, Dr. Maddox, who's not here, but when they came to Lincoln Hospital to give grand rounds, it was just an unimaginable opportunity, pardon me, to talk to them, to learn from their experience, to learn from their perspectives, and to get interested in this profession. And the same thing goes for nurses. This is for senior nurses in the audience, if there are any. What is your vision for your nursing career? Where do you see yourself in 1 year, 5 years? How involved are you in recruiting new nurses? Do you really talk to young nurses? Perhaps someone can catch a dream if you talk to them. Perhaps you have a very inspiring story that you can tell them. And perhaps a young nurse can open her career up just to be like you. How's that? Isn't that the best reward that you can get? So I just want to leave you this. And again, I'm greatly privileged to have the association that I see so many people that have been my mentors. I met about 20 years ago, and it was my good fortune to have met them. I try to tell them individually how grateful I am, but if I cannot do that individually, here is a collective thank you. So I leave you this to think about. We are like dwarfs on the shoulders of giants. So we can see better than they can at a greater distance, not because we are smarter or because we have a sharper sight or any other better physical distinction. But ladies and gentlemen, we are carried high and raised by their size. Thank you.